Now, I mentioned right at the start, I'd just like to take a little turn now, because I mentioned right at the start that the key to this is really that organisations, if any of this is going to work, individuals and organisations need to embrace it. They need to appreciate that it's important, it's the way things should be done, and really take that turn to say, well, how are we going to do it now? What's out there? So just to take a step back, often, and what has occurred traditionally is that in healthcare and decision making, we generally do what we know works, the way we've always done things, and we're reluctant to change, okay? Irrespective of the fact there might be some better way to do it, but if we haven't looked at the evidence or the research, we're unlikely to know about it. But generally, there's very little reflection or critical thinking about practice, and the only thing that really triggers us or clinicians to turn around and say, okay, now we need to do something here, is if something goes wrong. But that's quite different to the way an evidence-based practitioner should behave. And these, here the reference from 1995, have actually been around a few years longer than that. The Sicily statement basically put into action said if you're an evidence-based practitioner, this is what should be taught to them, because this is essentially how they should behave. They should know how to convert information needs into answerable questions. So that's asking that all-important clinical question. Okay, but answering in a particular way that it facilitates them to track down the best evidence which to answer these questions. So they are a bit savvy about how to search and where to search. And quite different to the way a systematic reviewer would search, where me conducting the research for a systematic review, I would normally start at the bottom of the evidence hierarchy, which many of you are quite familiar with the primary research. The clinician looks to start at the top with the evidence. I'm not talking about, the Ian Haynes 5S or the 6S system, with the clinical decision support systems. They're trained to find the good oil and find it quickly in systems like JBI Ovid or in UpToDate or and the like. They must have the skill of being able to appraise evidence critically. So even though it's scientific, even though it's research, even though it's published, we still don't believe everything we read, and they must take that critical mindset. And once they've discovered that evidence, what the evidence says, they need that ability to best determine how it should be implemented in their practice in that particular situation. And the final skill that an evidence-based practitioner should have is about evaluation of performance. And that might be in a systematic means, that it must be continued like a clinical audit, but also in a personal, reflective kind of way, that, that they sit down at the end of the day or the end of the week and say, well, how many times have I actually done this? How many times did I ask a clinical question? How many times did I turn to the evidence in my everyday practice? Was it just when I was a bit stumped and was hit with something new? But in my everyday work, did I turn around in the sort of decisions that I'm making pretty often? Do I ever take the time to turn around and say, has something new been presented in relation to this? Because if they never make that step, well, then they never have the opportunity to actually find if there's something better way of doing things. So this is really the way an evidence-based practitioner now is essentially the consensus of how they should operate. But that's easier said than done, because what they need around them is an organisation that appreciates that and is ready to give them everything they need to be able to behave or practice in that fashion. And that's really what's behind all of those tools and also all the information that you'll find in JBI Ovid. It's all about providing point of care access to already pre-appraised evidence in those evidence summaries, those snapshots. If that's not able, if that's not possible, an organisation should provide access to full text primary studies. Okay, and that includes systematic reviews, mind you. I wouldn't put systematic reviews in the pre-appraised bracket, but there are good systematic reviews and there are poor systematic reviews. Cochrane collaboration, JBI, we all have our own peer review process for these publications and this research, but that doesn't mean, just like what may be published in the Lancet, for example, just because they're high quality journals, it does not mean it is high quality gospel research. We need practice and policies available for an explicit evidence base. and establish systems to audit practice and ensure practice is evidence-based, and systems to monitor outcomes and improve them. So you can make the match between what an evidence-based practitioner needs to do and what an organisation needs to provide to help them do all of those things efficiently and effectively. And that's really what JBI is all about. And using those collaborative processes and working with individuals and systems, you'll see we know we have systems here that help you access the evidence, so to search for that, summarise the praised evidence. If you can't find that, there are tools like the Journal Club tool or JBI Rapid tool that help you appraise evidence and can work people, even novices, through the process of looking at research in a critical manner. And then certainly these last 3 points are about using the evidence. Tools to help use and ways to facilitate the transfer of evidence, so being able to create clinical practice manuals and also conduct clinical audits, just as an example.